Hello, we're here today with one of our new physicians in the Department of Ophthalmology at the University of Pittsburgh, Dr. Marie Hélène Errera, MD, PhD, who actually came to Pittsburgh from Paris, along with Dr. Sahel, or following Dr. Sahel a few years after he came. And this is exciting because she's someone that I haven't had a chance to talk to very much, so we're excited to learn a lot about her. Hello and welcome.
Thank you very much.
So Dr. Errera, I know you with Dr. Sahel worked at where did you train in Paris?
Yes, so I've done my residency in Paris in ophthalmology, and then I've done a fellowship in London in a hospital called Moorfields Eye Hospital, which is one of the main eye hospitals in Europe. I've done a fellowship there of retina, and medical and surgical retina, vitreoretinal surgery, and I've over-specialized as well in uveitis. Uveitis is inflammatory disease of the eye. And then I went back to Paris to do another fellowship and to be associate professor in ophthalmology there. And then I moved to Pittsburgh.
So that's a lot of education and training. What made you decide that you wanted to become a physician?
Oh, I'm a pharmacist first. And during my last year of pharmacy, we work in France. We have to work one year in hospitals, and then I discovered medicine, and I found a fantastic opportunity to use my knowledge in medication, pharmacotherapy, and pharmacology and medicine. That's why I'm very interested in inflammatory disease of the eye, because there is a lot of medication to deal with in inflammatory disease.
Oh, that's very exciting. I know you had a chance to work with Dr. Sahel at the Institut of Vision in Paris.
Yes.
Tell us what that experience was like.
Institute of Vision, as an Institute of Vision. Yeah, I had, so that's where I started working with imaging in the retina, and particularly they have, at the Institute of Vision in Paris, they have a big lab for adaptive optics, which is a fantastic and exciting new imaging for the retina, because we can magnify all the vessels and make them really bigger and try to understand all this disease of the eye, and particularly the degenerative disease of the eye and the inflammatory disease of the eye. So that's where I started to work, and I've done my PhD in immunology at the Institute of Vision of Paris, trying to understand the immunological mechanism of the autoimmune disease of the eye. So working especially on cytokines in samples from the eyes.
So what excites you about what we're doing here in Pittsburgh now, and what's being developed in the Department of Ophthalmology at the University of Pittsburgh?
So what I found when I arrived in Pittsburgh most exciting is the fantastic multi-imaging platform that you're having there, because there are all the machine for the retina, especially that we can dream of. And it's particularly interesting for clinical work, because we can really look deeper inside the eyes of the patient. And when we're doing retina, and especially inflammatory disease, you might have inflammation very deep in the eye, like in the choroid, which is behind the retina. It's very difficult to see just with the slit lamps that we are using in the clinic. So that's why with this new imaging device allow us to really look down deeper. And most of this new imaging device doesn't require any injection in the arm of the patient like we do for angiography, for instance. So we can really just take picture of the eye of the patient and look really deep and see what's going on, why the vision is blurry, why there is an inflammation. And what I find exciting as well is the lab, Dr. Rossi lab, he works on adaptive optics, and they are building this new device. They are using perimetry, they are using they work together with immunologists as well, Dr. Saint-Léger, and so we can really ask advice. And what I find interesting as well is the synergy and the way we're working with rheumatologists.
Oh,
At UPMC, there is a big department of rheumatology, not only for the adults, but at Children's Hospital as well. And so I've built we've built bridges between specialty rheumatology and ophthalmology. We've even created a combined clinic with rheumatology once a month at Mercy, where we see patients together in the same place, so patient doesn't have to come to different location, different visit, and we can talk in front of the patient, ophthalmology, rheumatologist, and that's exactly the same at Children's Hospital.
That's fantastic, and it's good to hear, because that's always been something that Pittsburgh and this institution has prided itself on, is the ability to collaborate, and I'm glad that's working for you.
And when we talk with colleagues, even in the world, there are very few places where you can work, have a combined clinic with rheumatology and ophthalmologists together. That's very rare.
That's fantastic. So, you know, that's a big move from Paris to Pittsburgh. What were the challenges for you taking this big step and moving from Paris?
Oh, it's a big step. Actually, you know, it's I think there are collaboration between Institute of Visions, you know, of both sides, Pittsburgh, Paris. So it makes things really easier because people were already working together, so people know each other. Especially, I knew Dr. Gross before, within the research side, and he tried to build bridges between clinicians and researchers. And what else? And it's a small world. So for instance, when I arrived here, I'm part of the team of the Retina team, and Dr. Danzigani is one of the Retina specialists at UPMC Pittsburgh, and we train as fellows in London. So I knew him when we were fellows. So it's a small world.
That's really great. All right. Well, I want to ask you a little bit about your research, but you helped me because you prepared some slides. So I'm going to go ahead and pull those up now. And then we can kind of discuss your research that way. I'd like to learn a little bit about your research. So if you want to take me through these, I'll go ahead and look through here. Obviously, this is so. Why don't you go ahead and tell me what we're seeing?
Yeah, we're seeing actually the slide just before was about my fellowship in England that I talked about, and then that's Moorfield. And then the next slide is about my fellowship in Paris. That's the main eye hospital in Paris, which is a very old hospital. And where I finished my training. And just to I put that slide just to make sure I don't forget any of the work I'm doing here clinically, surgically, because just to mention that uveitis disease can be responsible of cataract, can be responsible of retinal detachment. And so that's why part of my work is just to be in the OR and removing the cataract of patients with uveitis, or trying to fix their retina, or a membrane on the surface of the retina. We call them epiretinal membrane, and we remove them. I'm on call as well because in the ophthalmologic department, we take on call for cornea, glaucoma, of course, but I'm on call for the retina and the trauma of the eye. And I'm working in the acute care clinic as well. I just wanted to mention as well my work on adults and children as well, and my teaching to medical student, resident, and fellows, because we have a big team of residents at UPMC Eye Center, and we have 2 fellows for the retina. So if you can move on, thank you very much. So one of my clinic is at Mercy, that's where I operate as well. Otherwise, I see patient at INE Hospital at Oakland location and once a month at Children's Hospital. Next slide, please. Thank you very much. I just told you that uveitis is an inflammation of the eye. There are millions of diseases that can cause an inflammation of the eye. Most of them are infectious, autoimmune, inflammatory, can be trauma. And what is very important is that if we don't treat properly an eye with an inflammation, the patient can lose his vision, on her vision. Thank you. I just put some slides just to show the different causes of uveitis. Next slide. And what is very important is to know that perhaps 40% of the patient with uveitis, we never find a cause, but some of them we find sarcoidosis, for instance, which is a disease that gives inflammation of the front of the eye. And at the bottom right, you see a patient with conjunctival granuloma. They have red and painful eye. And the top picture, the picture on the top, is an anterior uveitis. That means that the patient has an inflammation only on the front of the eye. It can still be blind. Can threaten their sight. It can give a lot of pain and a loss of vision, and it can affect the back of the eye and particularly the choroid. That's what we call choroidal granuloma and choroiditis. Next slide. Just to show another cause of uveitis. This one is infectious. It's a parasite called Toxoplasmosis, and it can affect the retina and give blindness as well if untreated properly with antibiotics and if unrecognized. And this picture of Toxoplasmosis just show that the use of multimodal imaging in retina is particularly important. And on the right slide, the black and white picture are picture of fluorescein angiography. We inject the dye in the vein of the patient, and the dye enters inside the vessel of the retina, and we can really see better an inflamed area in the retina, and we can see the perfusion of the retina as well. Next slide, please. So just to show you the different angiographies that we have at UPMC Eye Center, we have the fluorescein angiography, and we have as well the ICG. It's quite rare to have this type of angiography in an eye center, and it's particularly important for the inflammatory disease of the eye because we can really see better the choroid. And when we see better the choroid, we can even monitor better the patients because we can really see better an improvement. Sometimes the improvement is earlier than the improvement of the vision. And it can show as well any involvement of the choroid, and all the disease of the eye doesn't give an involvement of the choroid. So it's important to find the cause. I just show two slides about pediatric uveitis that are the patients who have symptoms of uveitis prior to 16 years old of age. It's still 2 to 14% of the clinical uveitis practice. Next slide, please. And it's particularly challenging in children because these diseases are chronic. They are often result in substantial ocular complication and vision loss. And prompt treatment is really essential to reduce the complications. There is a difficulty with immunomodulators as the treatment for uveitis because it can be toxic for children, and the doses are important for children. And I really wanted to highlight the coordination between ophthalmologists and pediatrics rheumatologists. Sorry, I made a mistake on the slide. Because at UPMC Children's Hospital, Dr. Daniel Kietz and Dr. Rosenkrantz are the rheumatologists specialized in pediatrics, and they are fantastic to start treatment and to find the cause of inflammation. I go very quickly on these slides just to show the different diagnoses in pediatric uveitis and how the eye can be damaged on the right side. Next slide, please. For adults, we have created since last 2 years a dedicated combined uveitis and rheumatology clinic where we see patients in the same location at the same time with a rheumatologist, and they are helping us for the uveitis workup, initiation of steroid-sparing agent, and as soon as the patient has been seen altogether, ophthalmologist and rheumatology, so they can be seen separately later on in different clinics. Next slide, please. The surgical work, so patient with uveitis, they will have cataracts, as I said before. They can have retinal detachment. We can do biopsy of the vitreous inside of the eye and send it to the lab to try to exclude a viral cause or an infectious cause. So at Mercy Eye Hospital, we have the retina, the OR for retina, and we can do cataract as well. The research we are doing, we are collaborating with still with the French lab, Dr. Pac's lab about adaptive optics, and I'm working with Dr. Rossi in his lab and is with his students about adaptive optics and inflammatory disease of the eye. And we're working with one of these adaptive optics machines that you see on the right, which give fantastic pictures that you see on the center, black and white picture. And we magnify that this adaptive optics can magnify very well the different vessels on the surface of the retina. At the very center, you're seeing a vein, an inflamed vein. And what we try to do is to try to understand what's going on when those vessels are inflamed. Because there are a lot of complications of inflammation of vessel, of retinal vasculitis, that's a medical term. We can have vein occlusion, we can have an artery occlusion, and that has a massive impact on the vision of the patient. They can lose their side vision. And that is particularly important as well to do research to try to better monitor the treatment of those patients, because most of the patients with an inflammation in the back of the eye will have a long-term immunomodulatory treatment. They are steroid-sparing agents, and we don't know for how long to use them. Usually, the average is 2 years. Patient needs to have blood tests every month, usually with those medication. We need to make sure that they don't get any infection because they are more sensitive to infection. So it's very important to use a lower dose possible and not on the very long term. So that's why we are interested in this new machine to help us to monitor better those diseases.
Okay.
And the next slide is about some research we're doing with the other retina specialists here at UPMC. We are working with Dr. Denzigani, Dr. Shablani, Dr. Martal, Dr. Eller, Dr. Anitakis, and we're trying to try to find the better way to use this new machine. OCT angiography, for instance, give picture like angiography without dye injection, which is very useful, and it allows us to see really deep in the retina, in the choroid, what are the structure of the eyes that are inflamed or damaged by this retina disease. And we're very proud because one of our paper has been recently accepted and is just show how to use this new machine in inflammatory disease, and particularly in white dot syndrome. White dot syndrome are just some of these uveitis disease that affect the retina and the choroid. And so we're very proud of this recently. Next slide. And all day, every day, what we are doing with the rest of the team as well of ophthalmologists. We're teaching medical students, we're teaching residents, fellows, not only in the OR, not only in the clinic, but when we are doing the rounding at the bedside, they have teaching every morning, proper teaching. So that's exciting and very interesting part of my work here.
Thank you. That was really interesting. I just, you know, uveitis is something that I think a lot of people don't know a lot about. Obviously, you know, inflammation in the eye, I'm sure, very painful, certainly can cause damage. You can see that there's a lot of, you know, important use for the imaging that you're doing, and certainly a lot of use for the different therapies and other things that you're looking towards developing. And so it's an interesting area to learn about. Is there a reason that this sort of became very special to you or of particular interest to you in trying to study it and learn more about it?
About uveitis, it's
Yeah.
mainly is because it concerns the retina, and I find the retina fascinating, definitely. And because there, as well, it's very interesting because there are a lot of new machine, new device, new technology in the domain of retina. So in surgical retina, but in imaging as well. That's why it's very interesting. As soon as we have a new machine, we want to know how to best use it and how we that can help better our patients as well. And it's very useful as well, generally to monitor the disease. We try to find the less invasive imaging we can have, because the gold standard is still fluorescein angiography, but fluorescein angiography, we need to inject the dye in the vein of the patient. We need to wait 30 minutes. There is a risk of allergy for the patient. So that's why finding new imaging technology is very useful. And the patients are very happy to get to try them because they see that it's faster, less painful because there is no cannula in their vein, and it's better for us really to monitor the disease and to tell the rheumatologist, okay, with this recent image we've done to the patient, we're really sure that the inflammation is gone, the eye is quiet, there is no uveitis, so we can safely taper down the treatment. And so it's useful because you need to keep in mind that the rheumatologists, they can't see inside of the eyes. They really rely on us to tell them what's going on. They rely on us as well to tell them the type of uveitis that helps them to find the cause. And there are so many causes, infectious. It can even be a cancer that looks like uveitis. So that's very important to diagnose it as quick as possible and to make sure of your diagnosis. We as well rely very much on the rheumatologist because they are the one who are going to help us to find the cause. They are the one who are going to initiate the treatment. We collaborate with them just to try to find perhaps the best treatment depending on how the inflammation is, depending on the age of the patient, because most of this treatment can be dangerous if the patient is pregnant. So we need to think of the patient is older. We need to find some safe treatment if it's a child. So all the imaging we can have that can help us to find the cause of the inflammation and to monitor it better when it's under treatment. It's fantastic to work on this new imaging.
Well, thank you. It is very interesting. I learned an awful lot. So thank you, Dr. Errera, and thank you for doing this interview, but also welcome to Pittsburgh.
Thank you very much. Thank you very much for your questions. Thank you.
Look forward to more opportunities to learn as we keep growing and developing as a department.
Thank you very much for asking me to present myself and my work. Thank you very much.